I'm Dr. Sridhar Kalyanasundaram. We had discussed in a couple of videos on fluid balance, and in this quick video I'll discuss about sodium balance in the very initial few days in an extreme preterm or a premature baby. So we discussed temperature regulation and humidity, both of which have a significant role in the sodium balance as well. So in the newborn period we encounter two important situations. One is hyponatremia in a sick term baby or a baby following respiratory distress, and hypernatremia in extreme preterm baby. Both are due to different reasons, and we will quickly discuss how we approach each situation. So when a term baby with respiratory distress is admitted, it's common practice to restrict fluids, and even in more mature babies and in the growing premature babies, it's preferable to keep the volume on the drier side as best as we can. So we monitor them, we look at their sodium, we look at their weight gain, we try to fortify the feeds to bring the calorie requirements up even with the restricted fluid. So relative fluid restriction has been shown to be beneficial. It reduces risk of PDA, it reduces risk of NEC, it reduces the severity of BPD, and it's also one of the treatment measures for both PDA and BPD. The growth need not be compromised because you can look at optimizing your calorie intake even when you're restricting fluid to some extent. So if it is a growing premature baby, you can give the breast milk and continue the fortification a little longer, and if the baby needs formula, you can change to the low birth weight formula if you're not already on it, or the preterm formula. So you can improve the calorie content and restrict. When we talk of the newborn period, we're talking of hyponatremia in a term baby with respiratory distress, or a baby with infection, suspected infection, a baby following perinatal asphyxia. A borderline preterm baby with transient tachypnea as well may have the same situation. So the most common reason is syndrome of inappropriate ADH secretion, because any of these factors I mentioned can trigger this. And what happens here is that the antidiuretic hormone is secreted inappropriately in excess, and as we know, it's known to retain the fluid, free water in the collecting duct, so there is hemodilution. So the associated factors we will see is lack of weight loss and reduced urine output. So both these will be associated. The urine osmolarity, the urine electrolytes can be measured, but it is not essential, because if the clinical setting goes with it, you get a dropping serum sodium with the lack of weight loss in the first couple of days. Most probably you're dealing with SIADH. It's normal not to give electrolytes in the first 2 days because most babies shed their extracellular water, and this weight loss helps to mature the renal function. So we actually want to encourage this, and when this doesn't happen, we look at these aspects. So how do you manage syndrome of inappropriate ADH secretion? Your aim is to increase the serum sodium. You don't necessarily need to give additional sodium. You restrict the fluid, and invariably it starts improving on its own. In the rare cases when it is severe, a single dose of diuretic might help to shed the free water load, but you may have to start supplementing sodium as well. And if you start with 50 to 60 ml per kilo per day on day 1, and you restrict to 50 ml per kilo, for example, once you see the hyponatremia, you also monitor the urine output of the baby. If the urine output is not increasing, the baby continues to gain weight. Such cases you can weigh after 12 hours again, and you repeat the serum sodium, because if it goes below 125, you may need to give additional sodium to correct it further. So this is about syndrome of inappropriate ADH secretion. So relative fluid restriction and monitoring are the main things. Diuretics are very rarely needed, and that too just a single dose, because diuretics are not safe medicines. They have multiple effects on different organ systems, and the fluid balance gets upset as well. The hypernatremia in the very premature babies is because of insensible water loss, and so that's used as a guide to how much humidity you need to give, and also the temperature control. So I've already discussed this in detail. You don't give serum sodium to these babies in the TPN or the fluid till the sodium starts dropping to normal levels. So if you are starting to feed these babies, you see these are extreme premature babies, it will be very small quantities we are talking about of the milk, trophic feeds mostly. So increasing the milk doesn't need to consider the sodium content of the milk, because it will reduce as your hydration improves. So adjusting the humidity, increasing the hydration, these are keys. In extreme premature babies under 24 weeks, we have to be aggressive with the fluid balance, because these babies may also have hyperkalemia related to cell breakdown. they may have a higher risk of renal failure if your fluid balance is not aggressive. So don't hesitate to give more than 120 to 150 ml per kilo even by end of first to second days. If you see hypernatremia, if you see that the baby is losing weight, be aggressive with the fluid balance in the first 24 to 48 hours. I hope this simple video helps, and please share. Thank you.